Thank you, friends, for coming in this weather. Really happy that so many managed to come. So, without much delay, let's start because we have to be early also. So, I don't want to waste too much of time. Let's have association matters.
Respected Vice President Nambiraj sir, other senior members of Kannur IMA, and my dear friends. Association മാറ്റിൽ പ്രധാനമായിട്ട് പറയാനുള്ളത് ഈ കഴിഞ്ഞ ആഴ്ചയിൽ നടന്ന IMA സ്പോർട്സ് ആക്ടിവിറ്റീസ് ആണ്. ഇന്റർ ബ്രാഞ്ച് ഡിസ്ട്രിക്ട് ഫുട്ബോൾ ടൂർണമെന്റ് കഴിഞ്ഞ പിലാത്തറയിൽ വെച്ച് നടന്നു. നമ്മുടെ ബ്രാഞ്ച് FC കണ്ണൂർ IMA ആണ് അതിൽ വിജയിച്ചത്. അവരെ അനുമോദിക്കുന്ന ഒരു ചടങ്ങ് CMAക്ക് ശേഷം ഉണ്ടാവുന്നതാണ്. നാളെ ഇവിടെ ചെസ്, കേരംസ്, ഇന്റർ ബ്രാഞ്ച് ടൂർണമെന്റ് നടക്കുന്നുണ്ട്. നാളെ വൈകുന്നേരം ഒരു 5:30 മുതൽ 9 o'clock വരെയാണ്. 20ഓളം മെമ്പർമാരെ രജിസ്റ്റർ ചെയ്തിട്ടുണ്ട്. എല്ലാ മെമ്പർമാരെയും നാളെ എത്തിക്കുന്നു. അസോസിയേഷനെ പറ്റി പറയാനുള്ളത് CMA
Introduction of this.
Dr. REJINATH SAGAR, presently working as consultant in ENT at Dhanalakshmi Hospital, Kannur, and at ENT and endoscopy clinic in Papalശ്ശേരി, Kannur. Did MBBS from Kasturba Medical College, Mangalore, in the year 2000. DLO from Kasturba Medical College, Nepal from 2001 to 2003. Was awarded the Best Outgoing PG in ENT for the year 2003 from Manipal University. Was associated with Periyar Medical College from the year 2003 to 2010. Trained at Coast in France under Professor Robert Vincent in otology in the year 2010. Awarded gold medal at the temporal bone dissection course conducted by Padma Shri Professor Mohan Kamareshwaran, Chennai in 2008. Attended several national and international workshops and conferences as faculty. Special interest in otology, especially in hearing reconstruction surgeries. Married to Dr. Sudhi, a radiation oncologist, working at Medical College, Periyar. 2 children, Master Adhinath Sagar, studying in class 9, Chinmaya Vidyalaya, and Anvita Sagar, studying in 5th standard in same. With this note, I invite Dr. REJINATH Sagar for the talk.
Good evening, respected seniors of Kannur AMA. I'll try to make my talk short, as it's a big week and it's raining heavily outside. So I divide my talk into two parts. One is diagnosis and second is management of acute vertigo. As the slide shows, something rotating, that is what most of the patients see. Now, vertigo and dizziness are very common symptoms in the general population. Prevalence is around 5 to 10%, particularly common in individuals over 40 years of age. It will be the first reason for a medical visit in a patient over 65 years of age. These are the four factors that comes in the diagnosis and management of vertigo. First is understanding the patient's description. Most of the time, patients find it difficult to convey what exactly that is experiencing. The second is from our part, meeting the patient's expectation, because most of them expect to meet the vertigo within the first practice. The third is the patient-related practice. difficulty in adhering to the treatment, and anxiety. The fourth is misdiagnosis. Up to 80% of the patients are misdiagnosed, and only 20% may receive a correct diagnosis of vertigo. Just a brief anatomy of the vestibular apparatus. So the pathophysiology is quite complex with visual, vestibular, proprioceptive inputs, and it should get integrated in the CNS. And these are the basic things. We have 3 semicircular canals for the facial canals and 2 otolic organs for the linear acceleration. Now, normally we all stay in a perfect balance state because there is a normal balanced input from both the vestibular systems, and these get integrated into the central nervous system. Vertigo develops when there is an asymmetry either from the vestibular activity or when there is a bilateral vestibular activation. These are some of the things that we come across. Most common thing is the nystagmus. It has got a fast component as well as a slow component. And the second part is the physiological vertigo. At least we would have experienced more than once in our life, and that is motion sickness. And this is a mismatch between the visual, proprioceptive, and the vestibular units. What happens is when we are traveling, the eye tries to fix an object, but since we are moving, the object keeps on moving. So we try to fix it, but again it gets unfixed. So that stimulates the vestibular apparatus and triggers vertigo. Now we have to clearly find out what exactly the patient is experiencing. Is it vertigo, or that is it from an pathological perspective, or is it general, or from a central? So dizziness, different people have different meanings. It could be vertigo, weakness, syncope, resyncope, unsteadiness, and the expressions from the patient varies from patient to patient. Coming to etiologies, basically it is divided into 2 parts. One is central cause and the other is peripheral causes. So from an ENT surgeon's perspective, we always try to stick to the peripheral causes to see whether the patient is having peripheral vertigo, and we try to intervene and delete the peripheral cause, and simultaneously make sure that the patient does not have a central cause. If there is a central cause, we need to procure it to urologists. These are some of the etiologies coming from the central causes. CNS infections, tumors, infarct, hemorrhages, anterior inferior artery syndrome, multiple sclerosis, vascular migraine. From an ENT surgeon's perspective, we mainly seek for 3 things: whether the patient is having a migrainous vertigo, we mainly rule out a hypothyroidism, and if there is a history of trauma. Central causes include the most commonest, that is BPPV, labyrinthitis, vestibular neuronitis, venous disease, acoustic neuroma, perilymphatic fistula. Even wax infection can produce some neural failures in some patients, and sudden SLS. So our approach is to classify this into 2 groups. Central peripheral causes, if the patient having a BPPV or labyrinthitis or a vestibular neuronitis or any disease. Basically, we need to rule out 2 conditions: that the patient is not having a sudden sensitivity, because the vestibular cochlear arteries are intact. So if there is a sudden SM loss with vertigo, and if the hearing is not addressed properly, the patient may lose his hearing. And problem with sudden SM loss with vertigo is the patient might not have hearing loss. He will be more bothered about this vertigo. And second is, of course, an acoustic neuroma, because if you miss an acoustic neuroma, the life of the patient changes. Now, based on the history, we have to again find out whether it's a true vertigo, auditory, or central, and these are the routine questions that we ask. The patient is having an autonomic symptom, the onset and duration, whether the patient is having any auditory disturbances like tinnitus or loss in hearing loss, any neurological disturbances like ataxia, dysarthria, or things like that. Was there a syncope? any history of head injury, past medical history, over-the-counter medications, and of course, drug and alcohol intake. Now, based on the IB, we can divide the vertigo into these categories. Usually, BPPV lasts for a few seconds, usually 5 to 20 seconds. But the history, most of the patients will mislead you in the history. They'll say that when you ask you get vertigo when you turn to which side, they say that I get vertigo when I turn to both the sides. But actually, the patient might be having BPP on the right side, but when he gets vertigo, he will move to the opposite side. But when you do a positional test, you can really wait for that just move on the opposite. The BPPs are there, but they are rare. And BPP will not have any auditory symptoms. It will be just vertigo and vomiting. And usually, it settles by within 20 seconds. Usually, it takes around 18 to 20 seconds. Very lasts only few seconds, but always associated with some sort of strain. And then these patients will have ears as well as hearing loss. DIA will be again from seconds to hours and usually will not be associated with auditory symptoms. Illness disease, again it will be for few hours and it will be blocked in sensation area of centimeters. Vertiginous migraine will be for hours. Labyrinthitis and stroke and vestibular neuritis will be for days. Acoustic neuroma, cerebral tumors and other things will be running for months. And in acoustic neuroma, of course, there will be a auditory symptom. And this is one entity which crosses the barrier. It starts as a vertigo and then it goes for a central cause. Now, when we examine a patient, the first thing is feeling of status. And then detailed otoscopic evaluation, see for a post-oris or an endoral scar to make sure that the patient has not undergone any surgery. A tuning test, which is an ask for any patient with vertigo so that we can pick up any hearing loss. A fistula test, it's a very simple test, just put intermittent pressure over the tragus and see whether the patient develops nystagmus. If the patient develops nystagmus, it can either be due to a perilymphatic fistula or a superior semicircular canal dehiscence syndrome. Again, a very simple thing is just take a whisk of cotton and just rub over the cornea and see for a corneal reflex. Because if the corneal reflex is present, you can be very sure that the CP angle is clear. And even if there is a lesion in the CP angle, it is less than 1 centimeter. Because you lose the corneal reflex when the lesion is more than 1 centimeter. Positional test again, any patient with vertigo complaining of vertigo due to positional change, you should do a positional test. Gallery test, hardly I think anybody does nowadays. It is just included as a part of the routine examination to be done. And of course, we do cerebellar signs and lower 3 LFs to make sure the patient is not having a central cause. These are some of the investigations. We do a proton audiogram with special test, do an autoacoustic emission. Electrocochleography is not done routinely because it's invasive. We do a Vera test, that is auditory brainstem response, whenever there is vertigo associated with hearing loss. And of course, a CT or an MRI when you suspect a central cause. Even in peripheral causes, when you see a patient with ear discharge and vertigo, always look for a HRCT to make sure that there is no erosion of the label. This already have discussed about the peripheral and the central causes. These are the other causes, not routinely seen but should not be missed. Cervical spondylosis. And these patients usually give symptoms related something mimicking BPP. They said that they get vertigo when there is change of position. But it's actually not because of change of position, it's because of the extension or flexion of the neck that produces the cervical vertigo. Sensory defilement, neuropathy or visual impairment, anemia, hypoglycemia, and of course, hypothyroidism. Quite a few patients with vertigo, you find that these patients have hypothyroidism. And these are the drugs that causes vertigo. Aminoglycosis, not seen commonly nowadays. Usually in the literature, they mention about injection streptomycin given for pulmonary tuberculosis, which presents with vertigo. Now, peripheral lesions, while examining, the first thing that we always stick on to is a nystagmus. The direction of the nystagmus does not change. That's the first thing. Whenever you find a horizontal or a rotatory nystagmus, 99% is because of a peripheral lesion. If you see a vertical nystagmus, it's more likely to be of a central cause. And nystagmus always starts after a latent period, maybe few seconds. And then the symptoms aggravate after moving the head position in BPPV. Patients usually have severe vomiting or sweating. And if you do a caloric test, you find there is a decreased response on the side. Whereas when you, in vestibular, central vestibular lesions, the direction of the nystagmus can change. Mostly it is vertical. Vegetative signs are less and usually associated with neurological signs like hypopia, dysarthria, or numbness or ataxia. Coming to the most commonest cause for BPPV. Most common cause for vertigo in OP practice lasts less than 30 seconds. Occurs only with change of head. The nystagmus is transient, it is rotatory, and it is fatigable. You do a positional test, you are not very sure. You try to do the positional test again, the nystagmus will not be there. So when you do a positional test, you have to be very careful to pick the nystagmus in the first sitting. And it is basically because of the displacement of the otoconia. The otoconias are super like in the utricles and saccule. It gets dislodged from the utricle and saccule, and it enters into the semicircular canal. So semicircular canal becomes a gravity sensing organ. And typically it is diagnosed when you positioning maneuver test. And this is what happens. The utricle and the saccule will be somewhere here, and it gets dislodged into the posterior semicircular canal. So patient gets nystagmus and vertigo only when the head is tilted or shifted to that position. And one of the commonest symptoms the patient says, I was lying down in the bed, there was mobile was ringing. I tried to fetch the mobile by turning the head, I got vertigo. That's the most commonest description that they say. And the treatment for BPPV, long-term medications are not necessary. Acute phase, you can of course give something to make the patient comfortable. And basically it is position training. And this is a maneuver, that's a big sulfide maneuver that is done to diagnose BPPV. And you have to have the head end of the table should be flexed by 20. And you need to shift the patient, ask the patient to be comfortable, and then tilt the head by 15 to 20 degrees, and then slowly bring the patient down. And the head level should be below the shoulder level once it comes down to the first in the right lateral position, and should spend at least 5 to 10 seconds in that position, because peripheral vertigo nystagmus will appear only after a latent period. So you just check the right side and then bring the patient position to normal, and then again repeat the maneuver onto the other side and look for nystagmus. Usually it is a horizontal type of nystagmus, a rotatory crescendo pattern. And one more thing before doing a positional test is to make sure that you have a pocket or a kidney trapezoid, because a patient with acute BPPV might vomit. So you have to caution the patient that there is going to be a nystagmus, which may last for 20 to 40 seconds. And third point is you might vomit. And fourth point is, if the positional test is positive, you will be doing a repositioning maneuver, and patient need to take complete bed rest for 48 hours. You can admit or you can make it as an OP procedure, but patient has to take complete bed rest because otoconia takes around 24 to 48 hours to settle in the utricles and the saccule. So if you get a positional test on the right side, slowly tap the mastoid area, shift the patient's head to the left side until the nose faces the floor, as shown in the diagram, and then slowly bring the patient up. So the patient is going to get a nystagmus first and vertigo when you do a positional test on that side, and when you shift the patient to the opposite side, he is going to get a nystagmus and vertigo, which will last again for 5 to 6 seconds. And again, when you put the patient back to a normal position, is going to get a nystagmus for 1 or 2 seconds maximum. And of course, other tests that you do is to do a CT when you expect a cerebral mass or a hemorrhage or an infarct. ECG is a must for aged patients and patients who does not complain of classical vertigo. Whole calorie testing if facilities are available. An angiogram when you suspect a vertebrobasal insufficiency. But all peripheral vertigo cases should do a complete audiological and vestibular evaluation. Coming to labyrinthitis, again, it is not that rare but not that common, associated with hearing loss and tinnitus. It might involve the cochlear nerve alone, or it might involve the vestibular apparatus alone. But usually it is abrupt in onset and continuous. It may last for a few days. It starts with a slight episode of vertigo and vomiting. Then over a period of hours, it reaches a peak and then stays there for some time, and then slowly the patient starts to recover, depending upon the treatment. These are the 4 types of labyrinthitis. Serous is when you have a adjacent inflammation. Acute suppurative is again when you have a bacterial infection in the middle ear or meningitis or otitis media. This is the only condition where antibiotics are indicated. And of course, you need to admit the patient because they will be quite dehydrated and need to give IV fluids. Among the labyrinthitis, this is the most commonest that presents. That's due to toxic effect of medications. They will have tinnitus and high frequency hearing loss, vertigo in the acute phase, and then attacks in the chronic phase. And these are the commonest drugs that can produce labyrinthitis, chronic labyrinthitis. Chronic labyrinthitis because this is the second commonest labyrinthitis that we come across, and that is because of the chronic inflammation or infection in the middle ear, and it is basically because of cholesteatoma, which erodes the bony labyrinth, and the membranous labyrinth get involved. And usually the horizontal semicircular canals are most commonly affected because it is the most superficial one. Meniere's disease, first described by Professor Meniere in 1861. It's a triad of symptoms, and the diagnosis of Meniere's disease is basically on history. And maybe clinically you might not find that much of investigation except during an acute phase. These patients complained of 3 main things. Initially, they complain of block sensation in the ear, then they complain of roaring tinnitus, and then sudden vertigo and vomiting. And vertigo will be violent, usually lasting for 24 to 48 hours. And they get episodic symptoms. And one episode might be today, the second episode may be 3 months or maybe 2 years later. But in between these 2 symptoms, the patient will be symptomatically free. That is the most clinching finding that you get in the history of Meniere's disease. Recurrent attacks and vertigo lasts starting from 5 to 30 minutes, lasting for 24 to 48 hours. And basically it is because of the endolymphatic hydrops. What happens? The perilymph and the endolymphatic proportion changes, and the perilymph and the endolymphatic membrane breaks, and there is mixing of endolymph and perilymph. Basically, we ask them to have a salt-restricted diet because most of the time, patients with Meniere's disease, if you ask them, they would have had a salty meal before the attack of vertigo. And nicotine and alcohol withdrawal, and acute phase, you can give them acetazolamide. And these patients will not be having any CNS symptoms and positional vertigo, and positional tests and all those things will be negative. When you do an audiometry, you may find low frequency hearing loss. But since it is progressing over a period of time, the hearing will come down. Coming to vestibular neuronitis, you always suspect a viral etiology. It's always sudden in onset and increase over several hours. It takes almost few weeks to settle, and these patients we may have auditory symptoms, but tinnitus is usually present in all these patients, and the highest incidence is between 3 to 5 years. Vestibular ganglionitis, mostly by varicella zoster, affects the vestibular ganglion. Whenever you find a case of tinnitus with a viral infection and vesicles, always look for deafness and facial pulse. Coming to perilymph fistula, it is very rare. There are two types, congenital and acquired. And acquired is basically because of the atypical disease of cholesteatoma, which erodes the bony labyrinth. Iatrogenic basically comes in two forms. Especially when you have an extensive cholesteatoma, you are dealing with a high-speed drill, you might injure the horizontal semicircular canal, because horizontal semicircular canal, two issues are there. It is one of the most superficially placed canal, and the disease would have eroded the complete anatomy. The second is, that is of course by mistake. The second hydrogenic injury is a purposefully created perilymphatic fistula, and that is done when you do a sciatica or sclerosis, where you puncture the foot plate because the foot plate is fixed. So the patient's hearing is gone down because the foot plate doesn't move. So you puncture the foot plate and then create an artificial perilymphatic fistula, and then put a piston, but you are ideally supposed to close the leakage with fat or muscle. There are very rare cases of perilymphatic fistula being reported in literature due to flight. That may be because of sudden decrease in the abdominal pressure that might result in a perilymphatic fistula. And perilymphatic fistula again clinically is diagnosed by just fistula test. Intermittent pressure over the tragus will produce vertigo, and the treatment is surgical closure. This is one entity that, as I said, start as a peripheral cause and then it move on to a central cause. Acoustic neuroma, now it is termed as vestibular neuroma. It is because of the tumors of the Schwann cell around the 8th nerve. Patient will initially complain of just tinnitus. May have some tinnitus which will not fit into any of the criteria. And as the tumor enlarges, and as I said, it reaches a size of 1 centimeter, the corneal reflex will disappear. And later they have truncal ataxia, and usually occurs in women during 3rd to 6th decade of life. Now, why I said that it should not be missed out is because the management of acoustic neuromas, it can be treated conservatively if the tumor is small. If the doubling of the tumor size in 6 months, if the tumor doubles in 6 months, then it needs to be surgically intervened. So that is one of the reasons why we shouldn't miss an acoustic neuroma. And so any patient with tinnitus, off sensation of the ear, and dizziness, if you find the corneal reflex to be reduced or absent, should always ask for an MRI with gadolinium, which is a gold standard diagnostic material. You find the tumor in the CP angle, it's quite a huge tumor, which is compressing and the corneal reflex is absent. This patient had some amount of facial involvement as well. So these patients, usually the neurosurgeons will work up and then they see for whether the tumor doubling is there in 6 months and if there is any obstructive hydrocephalus. In such cases, we always also do a auditory brainstem response, and then you find that these are the 5 waves that you get in a normal auditory brainstem response. And this is what happens when there is an obstruction to the hearing pathway. So when you have a tumor in the CP end, what happens is once it grows, it compresses on the cochlear nerve. So the signals takes time to pass from the cochlea to the brainstem. So there is a delay in the 5th wave. That is how it is diagnosed. Rare causes of malignancy. Temporal bone malignancies are quite rare, but temporal bone fractures are not that rare. You find 2 types of temporal bone fractures. You have a horizontal fracture and a transverse fracture. So a patient with trauma with a ear bleed, you can be happy in fact, because that means the labyrinth is intact, the facial is intact, the bleeding might be only from the extraorbital canal. But if the patient doesn't have a bleed and has got vertigo, that is that the patient is having a transverse fracture of the temporal bone. that carries a bad prognosis. The patient may develop a facial palsy in 24 to 48 hours, and they could be sudden process. Glomus tumors, again, only once it erodes the laboratory, it will produce vertigo. Usually they present with uncertainty. These are the conditions where we need to put a line, where we intervene and where we need to refer. These are the red flags. Patient with vertigo, presenting with cranial palsies, papilloma, diplopia, severe headache, especially in the early morning. These are persisting worsening or equilibrium attacks or any other cerebral signs. We need to refer the patient. Coming to the management. Only in severe venous disease may require chemical ablation with gentamicin or endolymphatic cyclic compression. But problem with intratympanic gentamicin or endolymphatic, especially with intratympanic gentamicin, is the patient will lose the hearing in the long run because it's an ototoxic drug. So it is something called as a chemical ablation. So we reserve it only for refractory cases which does not respond to medical management and where the hearing is cracked. Otherwise, the blame will come on us where they say that my hearing was okay, but since you did a procedure in the ear, my hearing came down. Epilepsy management of BPPV is a gold standard treatment for the management of BPPV. You can give some labyrinthine sedative just to put the patient in the comfort zone. There are quite a lot of drugs available: diamond hydrate, propofuracin, promethazine, beta-histine, senoracin. Now there are combinations as well. Now, what is the need for the management of acute vertigo? One is risk of morbidity, impairment of the quality of life. It shouldn't go in for chronic vertigo, and they shouldn't be an economic burden to the patient. So why should we give vestibular suppressants? This is what happens when there is vertigo. When there is a dysfunction of the vestibule, there is hyperactivity of the neurons, and this gives fault signals to the brain, and that results in acute vertigo. So when you give a vestibular suppressant, what happens is there is decreased hyperexcitability, so there are no fault signals that go into the brain, so the vertigo is better. So one of the commonest drugs that we give is propofuracin. It has stood the test of time. Anti-muscarinic as well as an anti-dopaminergic drug. It relieves the patient from vertigo and also from nausea and vomiting. If you give intravenous, there is a chance of patient developing extrapyramidal symptoms. But if you give it orally, the chance of getting extrapyramidal symptoms are very rare. But we give propofuracin sometimes intravenously, especially when taking up the patients for sleepy surgery. Because when we put the piston, the patient is going to have vertigo. And if we changes his head position, because most of the time the sleepy surgery is done at a low pace, so that we can assess the movement on tape. So we give them propofuracin IV in such cases. But otherwise, even for BPPV or venous disease, some people give equally to doses. Give at the rate of 5 milligram per kg TDS or minimum 5 days to maximum 7 days. Senoracin is another drug of choice. It has got a labyrinthine sedative effect. It also stabilizes the vascular endothelium, reasonably safe, but problem is it interferes with the central compensation. The next drug that we have is beta-histine. It increases the cochlear blood flow as well. Not that sedative. It's not a CNS depressant. So the advantage is it will not interfere with the central compensation. Because when you have a labyrinthine dysfunction, the central nervous system will overcome that and try to compensate for the hypoactive or the hyperactive labyrinth. So if you give a drug that will interfere with this compensatory mechanism, that means the recovery is again prolonged. The initial doses can be 16 milligram 3 times daily or even 24 milligram BD, and a maintenance dose of 24 to 48 milligram daily for around 2 weeks. So to summarize, ensure that what exactly the patient needs by disease, whether it is central cause or peripheral cause, or maybe the patient is having a cardiac issue or anything like that. And try always differentiate the real cause for vertigo. And again, central causes are usually insidious and more severe, while peripheral causes are mostly abrupt and benign. And always rule out a sudden SN loss, because that can have a lot of medical legal implication as well. And it is quite easy to rule out a SN loss. You just have to just whisper something to the patient's ear and make sure that the patient is hearing on both the sides. If you have a tuning fork, yes, fine. But problem is when you use a tuning fork, there could be a cross hearing. So that could be mistaken if you don't mask the ear properly. So always try to treat the underlying disease, like quite a patients with migraine, they develop migraine as vertigo, and whether the patient is having any vestibular, vertebro-based ischemias or any other central causes. And if the patient is having venous disease, make sure, advise them to, more than a low salt diet, ask them to have a restricted salt diet. That is, avoid salty meals. That is the best thing that they can do. Diuretics only in acute cases. Vestibular neuronitis, only if it is suppurative, you need to give antibiotics. And for BPPV, it is always particle repositioning maneuvers, and that is a gold standard treatment for the management and treatment for benign positional paroxysmal vertigo. I think I have not bored you much. It's a tallest tower. If you go on top of it, you will feel vertigo. You will feel giddy. And one of the reasons is the proprioceptive senses will not work properly, because the entire structure will be shaking in the normal gravity and the wind. So you feel that you are going to fall. That is probably what exactly dizziness means, and not a vertigo. Thank you.
Thank you very much, Reji. Any questions and comments, please? Yes. Yes.
See, ideally, it would be acute phases always chlorprochlorosin that is going to happen. And then once the symptoms are better, you can shift it to a beta-acin or a cinnarizine combination. But again, if the patient is having a sort of a motion sickness type, because sometimes because patient might not give the complete history, they would have had a trip somewhere, and then they would have come and told you that he is having, or the patient is having vertigo. In such a case, chlorprochlorosin might not work properly. But otherwise, I feel that in my experience, for acute cases, chlorprochlorosin works very well. And what the protocol that I follow is, we put them on chlorprochlorosin for first 3 days, and then review at the end of third day, and then reevaluate, and then continue for another 2 more days. Because basically, we need to get the central compensation back. But cases like venous disease, vestibular neuronitis, we put them on beta-acin or cinnarizine for maybe 2 weeks. Again, patient with cervical vertigo, we put them on beta-acin or cinnarizine for 3 weeks. That's the protocol that we follow. But combination per se, I don't agree for acute vertigo, because patients will be having vomiting. So the advantage of chlorprochlorosin is it can be given separately.
Any more questions? History is the most important part of this. I have had patients who have 6 years, but I don't know. But then when you go into detail, they actually find that jokes and so on, and turns out to be issues. So they say narrative can be anything, should really go into detail.
അടുത്തത് നമ്മുടെ ഫുട്ബോൾ ക്ലബിനെ ആദരിക്കുന്ന ചടങ്ങാണ്. കഴിഞ്ഞ ദിവസം പിലാത്തറയിൽ നടന്ന മത്സരത്തില് കഴിഞ്ഞ ദിവസം പിലാത്തറയിൽ നടന്ന ടൂർണമെന്റില് കണ്ണൂർ FC IMA വളരെ നല്ല പ്രകടനമാണ് കാഴ്ചവെച്ചത്. ആദ്യത്തെ മത്സരങ്ങളിൽ പയ്യന്നൂരിനെയും പുത്തൂറമ്പിനെയൊക്കെ വളരെ നല്ല മാർജിനിൽ തോൽപ്പിച്ചതിന് ശേഷം സെമിഫൈനലിൽ തലശ്ശേരിയെയും നല്ല മാർജിനിൽ തന്നെ പരാജയപ്പെടുത്തി. ഫൈനലിൽ നല്ല പോരാട്ടമായിരുന്നു. തളിപ്പറമ്പ് ബ്രാഞ്ചിനെ 2-1 നമ്മുടെ ടീം പരാജയപ്പെടുത്തി കപ്പ് നേടിയത്. ടൂർണമെന്റിനെ പറ്റിയിട്ടും അതിന് കൂടുതൽ കാര്യങ്ങളെ പറ്റി സംസാരിക്കാൻ വേണ്ടി നമ്മുടെ ക്യാപ്റ്റൻ വരദരാജ് സാറിനെ ക്ഷണിക്കുന്നു.
Dr. Nirmalaj sir, Dr. Rajmohan, senior members, friends, colleagues. ഞങ്ങളുടെ IMA കണ്ണൂരിന്റെ ക്ലബ്ബ് FC കണ്ണൂർ IMA ഡിസ്ട്രിക്ട് ലെവൽ ഫുട്ബോൾ IMA ഫുട്ബോൾ ടൂർണമെന്റ് ജയിച്ചതിന് ഞങ്ങൾക്ക് നൽകിയ ഈ സ്വീകരണത്തിന് ആദ്യമായിട്ട് നന്ദി പറയുന്നു. ഈ കണ്ണൂർ IMA മെമ്പേഴ്സിനെ ടീമാക്കിയിരിക്കാൻ മറ്റും ഈ കണ്ണൂർ IMA ധാരാളം സഹായങ്ങൾ നൽകിയിട്ടുണ്ട്. കഴിഞ്ഞ ആഴ്ച എനിക്ക് തോന്നുന്നില്ല, കഴിഞ്ഞ ആഴ്ച ഇവിടെ നമ്മുടെ ജേഴ്സി റിലീസ് ചെയ്തിരുന്നു. എല്ലാ തരത്തിലും കണ്ണൂർ IMA എസ്പെഷ്യലി ഡോക്ടർ മോഹനും ചെയ്ത സഹായത്തിനും സഹകരണത്തിനും നന്ദി. നമ്മുടെ ലൈഫിൽ ധാരാളം സ്ട്രെസ്സുകൾ ഉണ്ടാകുന്നുണ്ട്, പ്രൊഫഷണൽ, സോഷ്യൽ, ഫാമിലി. അപ്പൊ ഈ സ്ട്രെസ് നോക്കിയിട്ട് ഓരോ ആൾക്കാർക്കും ഓരോ തരത്തിലുള്ള സ്ട്രെസ്സുകളാണ് ഉണ്ടാകുക. നമ്മുടെ ലൈഫിലെ സ്ട്രെസ് നമുക്ക് ഈ സ്ട്രെസ് മാറിയിരിക്കാനുള്ള ഒരു വഴി മരുന്നുകൾക്ക് വരുമ്പോൾ നമ്മൾ വേറെ ഇഷ്ടമുള്ള ഒരു വിനോദം, കായികമോ മാനസിക കല എന്തെങ്കിലുള്ളൊരു ഇതിലേക്ക് മാറുകയാണ്. അതിൽ കായിക വിനോദം ചിലർക്ക് വളരെ ഇഷ്ടമുള്ള കാര്യമാണ്. അപ്പോൾ നമുക്ക് ഈ കായിക വിനോദത്തിലുള്ള ചെറിയ ചെറിയ കാര്യങ്ങൾ നമുക്ക് വലിയ വലിയ സന്തോഷങ്ങൾ നൽകും. അത് ഓരോ ആൾക്കാരുടെ അതിന്റെ ത്രഷോൾഡും അതിന്റെ വ്യാപ്തിയും വ്യത്യസ്തമാണ്. പക്ഷെ എന്തായാലും ഈ കണ്ണൂർ പിലാത്തറ നടന്ന IMA ഡിസ്ട്രിക്ട് ലെവൽ ഫുട്ബോളിൽ ഞങ്ങൾ ജയിച്ചതിൽ എനിക്കും എന്റെ സഹ കളിക്കാർക്കും വളരെയധികം അത്യധികമായ സന്തോഷമുണ്ട്. നിങ്ങളുടെ സപ്പോർട്ടിനും സ്നേഹത്തിനും നന്ദി. മാത്രമല്ല, നിങ്ങൾക്ക് അറിയുമോ എന്ന് അറിയില്ല, ഈ കണ്ണൂർ IMA ഇതേമാതിരിയുള്ള ഈ CME നടത്താൻ തുടങ്ങിയിട്ട് കുറെ കൊല്ലങ്ങളായി. അപ്പോ ആദ്യത്തെ ടോക്ക് നൽകിയത് ഞാനാണ്. ഞാനും ഡോക്ടർ പ്രമോദ് ഇപ്പോഴും ഇല്ല, പിന്നെ പ്രതാപ് കുമാർ. അപ്പൊ അത് കൊല്ലങ്ങളായിട്ട് 2-3 ഡീക്കേഡ്സ് ആയിട്ട് ഇപ്പോഴും തുടരുന്നുണ്ട്. അപ്പോ ഈ ഒരു ഫുട്ബോൾ ഒരു ട്രോഫി വാങ്ങിക്കൊടുത്താൽ എനിക്കും ഒരു പങ്കുണ്ട്. അപ്പൊ ഇനിയും ധാരാളം ട്രോഫികൾ ഈ കണ്ണൂർ IMA വരട്ടെ എന്ന് ഞാൻ ആശംസിക്കുന്നു. ഞാൻ എന്റെ ടീം അംഗങ്ങളെ ഇവിടെ പരിചയപ്പെടുത്താൻ ആഗ്രഹിക്കുന്നു. ഞങ്ങളുടെ എല്ലാ മെമ്പേഴ്സും ഒരാൾ ഇങ്ങോട്ടേക്ക് വരിക. ഡോക്ടർ അബൂബക്കറിന്റെ ഫാമിലിയും വന്നിട്ടുണ്ട്, വൈഫും വന്നിട്ടുണ്ട്. ഡോക്ടർ ഹാദി എന്നെമായി തന്നെ റേഡിയോളജിസ്റ്റ് ആണ്. ഡോക്ടർ റജീസ് സൈക്കാട്രിസ്റ്റ്. റജീസിനെ നിങ്ങൾക്ക് എല്ലാവർക്കും അറിയായിരിക്കും. ഡോക്ടർ സിറാജിനെ നിങ്ങൾക്ക് പരിചയമുണ്ടാവുമെന്ന് തോന്നുന്നു. with our coach. രാജ്യമോൻ ഞങ്ങളുടെ ഈ വിജയത്തിൽ ഈ ഞങ്ങളുടെ ടീമിന് വേണ്ടിയിട്ട് ധാരാളം ആൾക്കാർ പ്രധാനപ്പെട്ട ആൾക്കാരാണ് ഡോക്ടർ രാഘവ ഇവരെല്ലാം അവിടെ ഞങ്ങളെ വളരെയധികം വേണ്ട അഡ്വൈസുകൾ നൽകി ചെയ്തിട്ടുണ്ട്. ഓക്കെ എനിക്കൊന്ന് ഓരോ അവരുടെ സ്വന്തമായിട്ട് ഡോക്ടർ ജിമ്മിനെ അറിയുമോ എന്ന് എനിക്ക് അറിയില്ല. ഡോക്ടർ ജിമ്മി സർജനാണ്. ഡോക്ടർ സിറാജ് മൈയിലാണ്. ഡോക്ടർ ഷാർഗിർ അഴീക്കോട് വർക്ക് ചെയ്യുകയാണ്. ഇതില് ഇല്ലാത്തവര് കുറച്ച് മറ്റുള്ള പ്ലേയേഴ്സ് വരാൻ പറ്റാത്ത കുറച്ച് പ്ലേയേഴ്സ് ഉണ്ട്. ഡോക്ടർ അവിനാഷ് മുരുകൻ പൾമണോളജിസ്റ്റ്, മിഥുൻ ബെഞ്ചമിൻ സർജൻ മിംസ് ഹോസ്പിറ്റൽ, ഡോക്ടർ ഇനാസ് ഓത്തോ, ഡോക്ടർ ആഷിഖ് ഫോറൻസിക് സർജൻ ജയിൽ ഡിപ്പാർട്ട്മെന്റ്. ഇവരെ എല്ലാവരും ഞാൻ എന്റെ പേരിലും എല്ലാവരും എനിക്ക് ഈ കണ്ണൂർ IMIT പ്രവർത്തനമായിരുന്നത് അവരോട് നന്ദി രേഖപ്പെടുത്തുന്നു. താങ്ക്സ്. അടുത്തത് ട്രോഫി അവകാശമുള്ളതാണ്. ഇപ്പോഴത്തെ ചെയർപേഴ്സൺ ഡോക്ടർ നിർമ്മലാസാണ് കൊടുക്കുന്നതാണ്.
Always in our showcase.
ഒറ്റ ഒരു കാര്യം കൂടി, ഈ ജൂൺ ഫസ്റ്റ് വീക്ക് തൃശ്ശൂർ വെച്ചിട്ട് ഡിസ്ട്രിക്ട് ലെവൽ IMA ഫുട്ബോൾ സോക്കർ ടൂർണമെന്റ് നടത്തുന്നുണ്ട്. അപ്പോൾ കണ്ണൂർ ഡിസ്ട്രിക്റ്റിനെ റെപ്രസെന്റ് ചെയ്ത് നമ്മുടെ ഈ പല പ്ലേയേഴ്സും മത്സരിക്കുന്നുണ്ട്. അതുകൊണ്ട് നിങ്ങളുടെ വെൽവിഷസും പ്രാർത്ഥനയും ഉണ്ടായിരിക്കണമെന്ന് അഭ്യർത്ഥിക്കുന്നു. നമ്മുടെ ഒരു വളരെയധികം ഫുട്ബോളിന്റെ ഒരു ആരാധകനായ ഡോക്ടർ അബൂബക്കറിന്റെ ഒരു ചെറിയ ഷോർട്ട് ഫുട്ബോൾ വീഡിയോ ഉണ്ട്. നിങ്ങൾ അത് കണ്ടിട്ട് മാത്രം ഭക്ഷണം കഴിച്ച് പോയാൽ മതി. അഭ്യർത്ഥന നിങ്ങൾ കാണാം.
dérange pas. Ah ouais. Ah, Shawty, avec l'étoile. Est-ce que ça marche? Ça va pas. On est livré pour aller plus haut. Avec le magicien, c'est le VERTIGO. On est livré pour aller plus haut. Avec le magicien. Oh, oh, oh. Comme d'habitude, on est calé. Comme toujours, ça va aller. On te met la grâce à gogo. Tous ensemble, on fait le show. On t'invite à la magie. Y a pas de raccourci. Oublie tes soucis. C'est bien faire la folie. On t'invite à la magie. Y a pas de raccourci. Oublie tes soucis. Oh, 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 oh. C'est pas seulement pour les bobos. Tout le monde dans nos mambo. On a dit si tu as le niveau. T'as joué, on est mis à la magie. Y'a pas de raccourci. Oublie tes soucis. Et viens faire la folie. On est mis à la magie. Le raccourci. Oublie tes soucis. Oh, 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 oh. Ah ouais. Ah, Shawty, on est grave. Est-ce que ça va? Ça va pas. On est livré pour aller plus haut. Avec le magicien, c'est le VERTIGO. On est livré pour aller plus haut. Avec le magicien. Oh, oh, oh.
Good evening, doctors. First of all, sincere thanks for IMA Kannur for giving us an opportunity to participate in the CME program. And sincere thanks to all the doctors who are attending this program. Also, Dr. REJINATH sir for taking this presentation very well. And as far as we are concerned, you all know we have got a brand, Stemetil MD, which is the #1 anti-vertigo brand. It's Procoprazin 5 mg mode-dissolving tablet. So Stemetil, as sir discussed, its advantages take care of all the associated symptoms, nausea, vomiting, and anxiety along with vertigo. So our sincere request, doctors like you only establish Stemetil to such a great extent. So still Stemetil is our backbone. So please do support us with Stemetil MD. Also, we have got Supra Plus, which is a multivitamin tablet. SAGAR is Rabiprazole, Domperidone. These three brands especially requesting. Once again, Stemetil MD, especially. And thanks to all the doctors, IMA Kannur, as well as Dr. REJINATH sir also. Thank you.
On behalf of the Kannur IMA, I express our sincere thanks to Dr. REJINATH SAGAR for his excellent speak on management of acute vertigo. Also, I thank all members of Kannur IMA for attending today's function. Our special thanks to the football club members for their outstanding performance in the field and bringing our trophy to the Kannur IMA. Thank you. Jay. And also to the sponsors, Harvard Farmer.
Thank you.